one of the registrars at UCT. And just to note that these meetings are still being recorded and put on YouTube for future reference as well, which is quite nice. So our patient today is Miss SD, a 46-year-old lady who presented to us first in December last year, complaining of a 9-month history of blocked nose, bloody otorrhea, and left-sided hearing loss. She had a left nasal polyp that the referring institution had done a polypectomy, and the histology showed in verbatim a low-grade spindle cell and stellate cell proliferation. They weren't clear as to whether it was malignant or not. She was fit and healthy, had an excellent effort tolerance, performance status 0, but she did have a history of smoking about 10 pack years and worked as a business manager for a business that was involved in cutting wooden panels, which will become significant just now. On examination of the ears, she had a left-sided otitis media effusion and conductive hearing loss. She had no external nasal deformity, but a massive left nasal polyp, basically filling the entire left nasal cavity, extending all the way back to the nasopharynx and even spilling over behind the septum into the contralateral side of the nasopharynx. She had a hyponasal voice, but no trismus, and her teeth looked normal. She had roughly normal visual acuity, visual fields, and eye movements, and her facial and palatal sensation was normal. So a CT scan shows basically a completely opacified left maxillary sinus, some bony erosion of the left inferior turbinate. It's only a single slice in the coronal and axial, but on the axial, you can also see how the tumor extends far posteriorly into the nasopharynx and spilling over behind the septum as well. We did an MRI because of the size of the tumor, and we wanted to make sure that it was abutting onto the lamina paprachea, and we wanted to make sure that there was no periorbital invasion or dural invasion at the base of skull. And thankfully, those were both clear with no invasion. And although this is only a T1 image, the other value of doing an MRI, particularly T2 weighted image, is to distinguish between tumor and obstructed secretions. But the T2, which I'm not able to show, showed basically just a massive tumor. So we took her to theater and found a tumor basically involving the left maxillary sinus, but the entire surface, all walls of the maxillary sinus, left ethmoid sinuses, including going all the way up to base of skull, posterior to lacrimal sac. So we did a left endoscopic medial maxillectomy via Denker's approach, taking care to preserve the infraorbital nerves, a left frontosphenoethmoidectomy, a left dacrocystorhinostomy, and biopsied the lacrimal sac separately, a left SPA ligation for hemostasis, and then at the end, we addressed the left-sided effusion with a myringotomy and put in a grommet. Her histopath report basically shows quite a confusing and tricky results with sheets of malignant cells with spindled morphology, pleomorphic nuclei and prominent nucleoli, and increased mitotic activity. There were some multinucleated tumor giant cells, but no invasion into the bone of the medial maxilla. They've got a long list of immunohistochemical stains that I've included for Prof. Hiller's benefit if he's still on the meeting. And so their differential basically was quite wide. They were considering a poorly differentiated angiosarcoma, sinonasal undifferentiated carcinoma, anaplastic plasma cell proliferation, or undifferentiated sarcoma. And they, on their further immunohistochemical stains, in conjunction with discussing with a professor in the United States, the consensus was made of a spindle cell carcinoma, which is quite a rare subtype of carcinomas. hence the interest in presenting this case. Then she actually returned to our department before starting adjuvant radiotherapy, complaining of a recurrence of sinonasal symptoms and tumor filling the entire left nasal cavity, bowing the septum over to the right, and even extending into the sort of pre-maxillary soft tissue swelling. She also had an acute left facial palsy for about 2 days. It was incomplete, affecting the marginal mandibular branch a bit worse, and all the other cranial nerves were normal. So at that point, we obviously did an MRI scan to assess the extent of erosion up to the base of skull to account for that facial nerve palsy, and to assess whether the tumor, to assess what management options we could offer the patient. And so on the image on the left, you can see the premaxillary swelling with the tumor extending into the premaxillary soft tissues anterior to the anterior wall of maxilla, extending all the way back. So it had basically recurred to the same extent as what it was before the surgery. On the image on the right-hand side of the screen, you can see that's a T2 image, and you can see the same extent of the tumor, but also that there's fluid in the left middle ear space. And so that's a recurrence of the otitis media effusion. So the discussion points are firstly just in general staging and treatment of sinonasal malignancies in general. Just one slide on the spindle cell carcinoma variation, and then a discussion on the treatment options for this particular lady. So the management options in general for sinonasal squamous cell carcinoma before the 1950s was basically only surgery. In the 1960s, neoadjuvant chemotherapy with 5-fluorouracil was trialed, followed by surgery, followed by adjuvant radiotherapy, and that sort of became the standard of care in the 1960s. In the 1980s, they then trialed topical chemotherapy. The 1990s had the advent of cisplatin, and then in the early 2000s was an advent of something called radplat, which I don't think I'm not sure if we practice in our institution, I don't think so, but it's basically intra-arterial cisplatin neutralized with systemic sodium thiosulfate and concurrent radiotherapy. So you get the beneficial effects of high-dose local chemotherapy, but hopefully minimizing the systemic side effects of the chemo. There's no randomized controlled trials comparing all the different options. So basically the sort of consensus for conventional treatment would be, for early stage disease, you would try and aim for single modality treatment with either surgery or radiotherapy. And for stage 3 to 4A disease, it would either be surgery plus adjuvant radiotherapy plus or minus chemotherapy if there's positive margins or distant metastases, or concomitant chemoradiotherapy without any surgery. There are some controversies for stage 3 to 4A, and that would be if a patient is sort of borderline resectability and there's a long waiting list, holding chemotherapy is sometimes used, but there's controversy as to which would be the best regimen in that regard. Then for stage 4B, it's broken down into, if the performance status is really good, you can offer concomitant chemoradiotherapy. And if the performance status is 2 or more, then palliative treatment would be given. The controversy there would be for stage 4B with good performance status, with limited dural involvement and a favorable histology. The controversy would be whether one can consider a surgery with curative intent. We do sometimes manage CSF leaks from base of skull defects. So there's a sort of thinking that one can maybe push the boundaries there and offer some surgery as well. So just briefly running through the surgical options. First of all, in terms of approaches, you can either do a lateral rhinotomy with or without a Weber-Ferguson extension, and the main downside to that would be the significant facial scar, or a sublabial incision for Caldwell-Luke approach, and the main risk there would be a risk of oroantral fistula, or lastly, a midfacial degloving approach if the tumor is located anteriorly in the sinuses. You just can't get very far posterior exposure. The endoscopic options would be either endoscopic endonasal approach for an early stage tumor in the maxillary, in the ethmoids or nasal cavity, or an endoscopic Denker's medial maxillectomy, which is illustrated in the three pictures at the bottom. So you basically make an incision onto the anterior wall of the piriform sinus, reflect the soft tissue lateral to that up to exposing the infraorbital nerve, V2, then reflect the mucosa on the medial side of that, exposing the nasolacrimal duct, and then drill out that the medial maxillectomy basically to get access to the tumor through there. If the tumor is located anteriorly or on the lateral wall of maxillary sinus, those are quite difficult to reach endoscopically. So different techniques have been made as adjuncts to that procedure, which would either be a septal window, where you make a window in the septal cartilage and put the scope from the contralateral side through the window into the anterolateral wall of maxillary sinus, or a septal translocation, where you basically dislocate the anterior wall, the anterior part of the nasal septum off the nasal spine, push it to the side, and then put the scope in through the ipsilateral nasal cavity, but with the anterior part of the septum bent over to the opposite side to improve the access. The surgery basically depends on where the sinonasal tumor is, but if it's a maxillary sinus carcinoma, then it would be a maxillectomy, and either infrastructure or suprastructure, depending on the site of the tumor, total maxillectomy, or an extended maxillectomy, where you take also, if necessary, pterygoid plates, zygoma, mandible, soft palate, or even contralateral maxilla. The management of the orbit in sinonasal carcinoma is controversial. The orbit's involved in roughly 10% of cases. The lamina papyracea is easily invaded by malignant tumors, but they often don't get past the periorbiter. That's a much stronger layer. However, if the periorbiter is breached, then it spreads quite rapidly through the orbital cavity. So there's always a debate between oncological safety versus trying to retain the function of a preserved eye. But the general trend in recent years has been towards a more conservative approach. Just for sort of terminology of what is removed and what is preserved in an exenteration versus an orbital clearance. Exenteration is where all of the contents of the orbit are removed and nothing is preserved at all, versus an orbital clearance is removing the globe, the muscles, fat, and periorbiter, but preserving the eyelids for cosmesis. So the prognosis can be described partly by the TNM staging, but also partly by Ongren's lines are used nowadays, but those were also preceded by Sebelow's lines, two horizontal lines dividing the nose and sinonasal sinuses into a suprastructure, mesostructure, and infrastructure. Liederman then added two vertical lines to make 3x3 quadrants. But like I said, Ongren's lines are now most commonly used to divide the maxillary sinus, particularly into suprastructure, which has a worse prognosis because of the proximity to the orbit, pterygoid plates, infratemporal fossa, and base of skull, or the infrastructure being anterior inferior to Ongren's line, which has a better prognosis. Just a brief slide on the spindle cell variation of carcinoma. It's a rare variant of carcinoma, occurring in less than 5% of all carcinomas. It has been reported in the larynx, sinuses and nasal cavity, and oral cavity. Its macroscopic appearance is quite variable, ranging from a polypoid nodule, it can be fungating, or it can be ulcerative. Rarely there are case reports of a large tumor with a narrow pedicle that can actually auto-amputate and be aspirated from the upper respiratory tract. The histology, like with our patient, is quite easy to confuse with sarcomas. And one of the sort of synonyms for spindle cell carcinoma is sarcomatoid carcinoma. But out of all the immunohistochemical stains, probably the most useful is P63, which is a marker of keratin. And if that's positive, that confirms the squamous lineage of the tumor. There is a high rate of local and regional recurrence. It's a very aggressive disease, as we saw with Our Lady, from having had a polypectomy a couple of months before coming to us. It had massively filled up the nasal cavity. And then after our medial maxillectomy, it again recurred massively within less than a month. There's debate as to whether spindle cell carcinomas are radioresistant, as reported by Minami in 2008, or radiosensitive, as reported by Olsen a decade before that. So to get back to Miss SD, I didn't go into the staging of sinonasal carcinomas, but basically for maxillary and nasal cavity and ethmoids, it's the T1 to 3 stages are different according to the extent of bony erosion, and for nasal cavity according to the number of subsites. But for all sinonasal malignancies, carcinomas, the staging of 4A and 4B is the same. So for 4A, it would be extension to the sphenoid or frontal sinus, cribriform plate, the skin of the nose and cheek, anterior part of the orbit, pterygoid plates or infratemporal fossa, or minimal invasion into the anterior cranial fossa, but with the dura being intact. T4B would be extension into the nasopharynx, clivus, orbital apex, cranial nerve involvement other than V2 and infraorbital nerve, and extensive invasion into the dura or brain. So Our Lady was then clinically staged as being T4B because of the acute facial palsy. And I didn't mention, but N0 neck and M0 no sign of any distant metastases. She had an excellent performance status. So we in conjunction with our oncology colleagues, they are hopefully going to be able to offer her concomitant chemoradiotherapy, starting off with a neoadjuvant chemo. Thank you very much. I'm happy to answer any questions.
Simon, thanks very much for an excellent presentation. I don't see any questions on the chat function, and I don't see any raised hands from our participants yet.
I've got one. We had invited Dr. Delvey to attend the meeting because she's the oncologist primarily looking after the patient.
Yes.
So we do have some specific questions, but Dr. Delvey, do you have any comments first?
Yes, I think your presentation was very comprehensive, and it did raise the points that this is a very rare tumor. There are no randomized controlled trials. Obviously, the fact that the tumor has grown so quickly is very worrying. But as you've said, the performance status is very good. The reason why we started with neoadjuvant or induction chemotherapy is the fact that the process of the radiotherapy takes a bit of time, and there is a concern that as one is waiting to do all the quality assurance checks for the radiotherapy, that the tumor would actually change in that time. So the neoadjuvant or induction chemotherapy approach in suitable patients is often used in low resource settings, and also in patients with bulky disease. She doesn't have nodal bulk as such, but the tumor itself is close to areas which we would in radiotherapy call class 1 organs at risk, with the nasopharynx being involved. You're quite close to the chiasm. There's the brain stem. You have to be, you know, the dose that we can give to those areas will be compromised because of the proximity of the tumor to those areas. So another reason, besides the fact as using it as a temporizing measure, is to try and decrease the bulk of the tumor, and also to basically shrink tumor away from these critical organs at risk. So one usually gives 3 cycles of neoadjuvant chemotherapy. Giving the neoadjuvant chemotherapy is also, in a way, prognostic. If she responds well to that, it signals for me. I haven't dealt with a lot of these patients because of its rarity, that there is a better chance for local control of the tumor. If she doesn't respond to the chemotherapy, it means that most likely we will have to move to palliation. Usually the treatment is intravenous 5FU. With the COVID situation and the fact that the patient lives in Knysna, one also has to take her social circumstances in that there are financial considerations, and also that she has a young family with her children being in matric this year. So she was given oral 5FU, which is a dispensation we've received from our pharmacy committee because of the COVID situation. So instead of being admitted for a week, she had the 1 agent given as an outpatient in the clinic, and she would do the rest of the 5FU at home, which is in the oral form. So I will be in touch with her via email because it is quite toxic, the oral 5FU. The hand and foot syndrome can be quite debilitating. We have had the oral 5FU is used quite often in the GIT setting, and there's actually been fatalities due to the debilitating diarrhea that the patients can have. So she's been instructed about all these side effects. One has to spend quite a bit of time with the patient explaining, and the need to present very early if you have copious diarrhea, as you may need to be hospitalized. So at every visit, we will be looking at the chest because there is that sort of sarcomatoid element to it. The risk of metastases to the lungs are very high. At the moment, we don't have any evidence for that. So at the next visit, there'll be more imaging just to have a look at that. That also obviously changes the prognosis. All in all, the prognosis is poor. The survival is poor, as one can understand from what you presented. But the performance status is good, and we hope the patient can be fit enough to tolerate treatment. Sometimes in head and neck, local control is very important, especially when it can be tumors that other people can see, and it's malodorous and having to live with your family. One almost, you'd have local control, and, if the patient passes away because of distant disease, that is almost in a way more acceptable sometimes to the patient than to have a fungating tumor, that clouds the memory of everyone who's in contact with that person. and also for the cell well-being. So sometimes one doesn't always just treat for overall survival, but also for that local control benefit, which can be very satisfying. So that has been our approach. Wow.
Thanks, Dr. Dalby, for that very in-depth overview. I think being a consultant is being able to answer these questions with attention divided. So thank you very much. Prof. Hiller, I see your raised hand, and I would please, before you comment, I would also please like to ask you, Prof. Hiller, if the spindle cell CA is a different entity, or if it's related to squamous cell carcinoma. Thanks, Prof. Hiller.
Good morning. Thank you very much for allowing me to talk. Good morning to everybody. Well, the spindle cell carcinoma is actually a biphasic tumor. So one has but it actually is of squamous cell origin, but it is a different meta-differentiation into a spindle cell component. And you can even have bone formation, or you can have even differentiation into muscle type tumors. But the main origin still remains that it is of epithelial origin. So spindle cell carcinomas are seen as a variant of squamous cell carcinoma in the head and neck. And they are notoriously difficult to diagnose because small biopsies can take usually before one has let's say, a sizable chunk of the tumor to analyze further. So often what happens is that you get indeed a spindle cell tumor morphology, which then one needs to work up. But one always has to find a reason in entertaining the most common diagnosis in the head and neck, and that is still, carcinoma derived of epithelial surface origin. So what is a clue to the diagnosis on histology is the fact that the spindle cell carcinoma is always in some way, but it's obviously difficult to haunt, related to the surface. So and that's actually a sine qua non diagnosis if you use H&E only, and is that if you have the surface epithelium, you can see the tumor actually arising or deriving from that surface epithelium, and then it transforms into a spindle cell carcinoma or spindle cell lesion, which looks very sarcomatoid. So the other name is sarcomatoid squamous cell carcinoma. So yeah, fortunately we do have immunohistochemistry. Can you just go back to the panel, the full list there that is being given to you for the diagnosis, and then I can actually talk to that.
Sure. Just a sec. There we are.
So you can see this is an impressive list, and it's very bewildering to see what really is of use for this diagnosis or not. So you see that there are 3 coming up as positive. And I do miss the P63 in this list, unfortunately. And you mentioned that's an important marker for diagnosing squamous cell carcinoma that's missing in this list. So yes, so basically the spindle cell carcinoma of the head and neck is positive for a cytokeratin marker, as you see here, and for P63. So if one has a spindle cell tumor that has got both high molecular weight cytokeratins as well as P63, then one does have a surface lineage or squamous cell lineage that's very highly likely in this tumor. If the only thing that one has to exclude on the P63 positivity is a myopithelial carcinoma, which is a lot less frequently seen in the head and neck. But what actually is very important, which I would like to tell you, because we're living in resource-restricted countries, is that one needs to apply immunohistochemistry with some kind of restriction because it's expensive. And this list is very expensive. And I think I would say this would translate probably in the region of how many are there? 20? One would look something like 12,000 Rand worth of immunohistochemistry. Which is very expensive to diagnose spindle cell carcinoma. And I don't want to really basically go into the reason why this all was done. But the most important thing is that in pathology, and that goes back to when we had very limited use of immunohistochemistry in the days that I was a registrar, it's still very important to apply a basic panel. And I think as clinicians, one should actually ask the pathologist before they go into a battery of these tests to say, well, can you tell us whether this tumor is, what is the basic lineage of this tumor? And there's 4 immunohistochemical markers that I always apply when, and it still works out perfectly when I'm sitting with a conundrum like this, in which you try an epithelial marker or a cytokeratin marker. You try a vimentin, which is basically a spindle cell, sort of a mesenchymal spindle cell marker, which is used both as reliability for immunohistochemistry and it's lost its luster a little bit with the modern pathology generation. But vimentin is still very useful in the diagnosis of spindle cell carcinoma because it's invariably positive, indicating that the tumor has actually undergone mesenchymal differentiation or has got is a bimorphic tumor based off epithelial cells with a mesenchymal structure. Okay, so, and then the other one is the S100 or the SOX10, which is great, which is eliminating melanoma and endocrine tumors. And then basically there is the CD45, which eliminates lymphoid tumors. So with that panel of vimentin and either MNF or CK5 or MNF and P63 as a second part, we would have actually clinched the diagnosis in 2 steps with 4 markers maximum. So it's, and then I'll quickly want to talk about the CD138. The CD138 is a non-specific marker in a lot of tumor cells, and basically it's a protein-glycan membrane antigen. It is expressed also in tumors of plasmacytic origin, so it's not really specific, but what it tells us is that it's a good target for antibody or antibody therapeutics. So in the modern age of monoclonal antibody therapy, CD138 is actually one of the candidates that is on the horizon for treatment of these tumors. But otherwise, it is mainly there for plasma cells. But it is positive in squamous carcinomas of the head and neck. But what actually we see is the lesser the expression of CD138 in the head and neck, the more aggressive the tumor is. So CD138 is a bit of a dicey diagnosis to use as a diagnostic because it's not specific. It's sensitive, but not specific. But I think we could apply that as a secondary marker to see if this is aggressive. So in this particular case, Dr. Dalby, it looks as if this tumor is still nicely CD138 positive, indicating that it might actually sort of respond reasonably well to your treatment.
Thank you, Prof. Hill. That's very reassuring to hear. I must say I agree with you wholeheartedly about communication with a pathologist. What one communicates, sometimes the only communication is what you write on the form as you are taking the biopsy. And also one should put down what is found on any imaging that you have available it's really invaluable to the pathologist. One really needs to work with your pathologist to get to the most likely diagnosis, and you need to give them all the information. So the importance of a multidisciplinary team approach, I can't emphasize enough. Sometimes one has to do it virtually, but the pathologist is a crucial part of that team, and one must always communicate with him.
Yeah, but what's also important is the cost limitations. And I think then, for example, if one would have applied the basic panel, which would have been just Vimentin and P6, Vimentin, cytokeratins, CD45 and S100, it would have been positive for 2 of them, which is Vimentin and epithelium, and then you can apply a P63 and you actually have clinched the diagnosis. Or even sort of go a little bit further down and apply CK5/6. So with 6 markers, one would have actually made a diagnosis, which would have been maybe a bill of 2,500 Rand. So it would be like, and then one would have to, yeah. So that would be, because basically what's important is to see what kind of tumor is going to respond well to treatment, to radiation treatment. And obviously with these biphasic tumor, it's a little bit of a dual issue because generally spindle cell tumors with mesenchymal elements actually don't respond primarily that well to radiation therapy. But epithelial tumors with an epithelial component like this spindle cell carcinoma, and it is still a carcinoma from a primary lineage point of view, respond much better. So I think that with the immunohistochemistry of identifying certain cytoplasmic intermediate filaments like DAC-D-star, one actually can already guide the radiation therapist to say, well, look, this is biphasic or this is monophasic, and already that gives you an idea about what you should be looking at when you want to treat this tumor. And I see obviously chemotherapy is being used, which I can understand because of the the mesenchymal characteristics of this carcinoma.
Yeah, thank you. Thank you for your input. I've really learned from this. I'm glad to see that there is a possibility that she would respond to the chemotherapy and one can go on to radiotherapy.
Thanks for all the input. Before we close off and go to the next case, I would just like to ask Kafui Searu in Ghana if he has any comments with regards to this case, and especially with regards to Denka's. I don't hear Kafui on the line. Let's go to the next case. Our next case is Dr. Charles Moyo, registrar at UCT. And Charles, you are you can share screen and
before you go on, you actually promised us to tell us something about the wood exposure.
Is it Simon?
No, it's me, Prof. Hiller.
Thanks, Prof. Hiller. No, I'm asking if Simon needs to say something about wood exposure. Or Prof. Hiller, can you say something about?
I actually don't know much about it, but I do know that, for example, wood exposure is a risk factor for sinonasal carcinomas, and particularly adenocarcinoma. But I think that it's probably not only limited to adenocarcinomas, but probably to a whole host of other carcinomas that one actually can encounter in the sinonasal region. So I think it is good to entertain the possibility of woodwork in the industry. And we know, is this patient coming from the Southern Cape? Or
from Nice, Prof.
Oh, that's classic. because of the wood industry in Nyasna. So that's always a red flag. But for those who are in the rest of Africa, it probably is true too. I think you just have to look maybe at what's happening in your country. But we know that the wood industry from the Southern Cape is workers in that wood industry, especially when there's dust, wood dust is a high risk factor for sinonasal carcinomas.
Thanks, Charles. Thanks, Prof. Hiller.
Shall I go and hear it? Okay.
Thanks, Charles. You can go.
Okay. Good morning, everyone. Once again, my name is Dr. Charles Moyo, and I will be taking you through our second presentation of the day. Without further ado, I'll go on to my presentation. So I obtained consent for the use of this patient's clinical data, and I have no intention of any copyright infringement. And the content of my presentation is referenced. So I'm presenting Miss MK. She's 32 years of age. She's HIV positive with a low CD4 count of 74. And on a background history of that, she defaulted in 2018. She was also previously treated for pulmonary TB in 2017. So she presented with a 3-week history of a barking cough with associated dysphonia, with a sore throat and odino dysphagia, with a progressive shortness of breath. So her dysphagia was non-progressive. She only struggled to swallow solids. She had associated sore throat, and shortness of breath was mainly with exertion and on lying flat. She didn't have any history of prior intubations. She didn't have any history of trauma. There was no history of any drooling or any history of foreign body ingestion. And on background history, she presented initially at the community health clinic. That was a week prior to presenting to us, where she was being investigated for a possible pulmonary TB. She had a sputum genespect which was done thereof, and which was negative, and a week prior to this presentation. She was a non-smoker. She had no history of any alcohol use. She didn't have any constitutional symptoms, and she actually works at a car polishing workshop. So on her contact with us on examination, she looked unwell. She had inspiratory stridor. However, she was not in respiratory distress. She was obviously dysphonic with a muffled voice. In terms of her vitals, she was afebrile. It is worth noting that at the referral center, they said she had a history of a temperature of 39. Her blood pressure was fine. She was saturating well, and she had a tachycardia of 123. She didn't have any lymphadenopathy in the neck, nor in the groin or axilla. She did have mild pallor. And on neck examination, she didn't have any lymphadenopathy in the neck. And when I examined her larynx, the larynx felt bulky, but it was mobile, and there was no tenderness. On throat examination, the mucosa in the throat was normal. She had grade 2 tonsils. Ear examination was normal. We couldn't do a flexible fiber optic nasal endoscopy at that time because the COVID status was unknown. She, however, had already a chest X-ray done, which was normal, not suggestive of pulmonary TB. And she had a lateral neck X-ray, which basically showed soft tissue swelling in the region around the thyroid cartilage, and also suspicious of a supraglottic structural swelling. Specifically, there was no thumb sign which could suggest an acute epiglottitis. At this point, I would open it up for discussion if anyone, with this information I have given, if anyone wants to share their thoughts in terms of the differential diagnosis in a 32-year-old RVD positive, a patient who presents with a 3-week history of a barking cough with inspiratory stridor, with dysphonia or muffled voice, no history of smoking, and no history of any alcohol use, and she's not on ART. I'll open it up for exam candidates, preferably.
Charles, do you want to choose someone?
Is Tasia there?
So I asked the students.
Hi, Charles. Thanks for the volunteering. So I think a 32-year-old HIV positive person, as you said, with what also looked like some fullness on the lateral X-ray that you demonstrated. So I mean, you think, you know, one has to go through all the differentials, infectious, tumor, granulomatous diseases. So I'll start with infection with this patient who is immunocompromised. So, you know, gene expert was negative, but that can be negative in a laryngeal TB case. So that's something that I think I would want to put high up in my differential diagnosis. If this is a chronic history, maybe I would, as you said, there's no thumb sign. Maybe it's not necessarily a supraglottitis, as you had mentioned, but that's something you also have to keep in your mind. Again, an immunocompromised person with a low CD4 count. I think you had mentioned the CD4 was 74. I think that's very, very low. So you have to think about tumors in this population, especially lymphomas, which are quite common in severely immunocompromised patients. And then any female that is between the ages of about 20 to 40 years old, that's the demographics that sarcoid usually presents in as well. So I'd want to do a chest X-ray as well and just see if there's any signs of any lesions in the chest, and perhaps consider a sarcoid of the larynx as well. So those are probably my main differentials. I'm not sure if anyone has anything else to add.
Thank you very much, Tasia. In the interest of time, I think I like your approach. It's quite good, especially in this young patient who is immunocompromised. But I would like to share this this table from Cummings. So there is a vast majority of differentials in terms of lesions or tumors of the larynx. The list is exhaustive, but however, you know, we need to take into consideration the patient which we are dealing with. You know, if it's a young female patient with sort of a subacute presentation who is also immunocompromised, you know, you tend to think of sort of like opportunistic infections on the list. You tend to think of HIV or AIDS defining malignancies as well. And you also need to also think of the chronic or inflammatory conditions of the larynx, or chronic granulomatous conditions of the larynx. And TB as well should be high on your list if in the context of HIV. So these were sort of our list of differentials when we saw this patient initially. We entertained possibility of an insidious onset of a supraglottitis, and we considered also opportunistic infections, be it TB of the larynx or cryptococcal infection, We also considered age-defining malignancy, like lymphoma or Kaposi sarcoma, or in our minds, we thought it could be an atypical presentation of a squamous cell carcinoma of the larynx, which could be HPV related, or which it could possibly be a malignant transformation of underlying papillomas, and also autoimmune diseases where like sarcoidosis were part of our differential diagnosis list. So in our initial management in the EC, we gave a status of dexamethasone and adrenaline nebs. She responded quite well to medical management in terms of Airway. And we started on empiric ceftriaxone, and we put on Airway observation as we obtained a COVID test, which came out negative. And then her blood results, white cell count was normal. However, on differential count, she had a neutrophilia and a lymphopenia. And she had a normocytic anemia of 9.3. She also had elevated CRP with a markedly elevated LDH levels as well. UND, she had a mild hyponatremia with a mild hyperkalemia and a raised urea. So after obtaining a negative COVID test, we proceeded to scope this patient. I will just forward the video to show the most important part. And of course, taking into consideration that airway symptoms had improved. As you know, you always have to be careful if you are to scope a patient with a suspected supraglottitis or epiglottitis, because you may lose the airway at any point. So as you can see, there was this marked sort of like cystic swelling of the both epiglottic folds, and you could visualize a sort of submucosal fungating tumor in the involving both false cords. And if you can see, of course, this the picture quality is not very ideal, but you can see that the epiglottis was also denuded. So basically, it was a fungating submucosal lesion, which at this point was involving the right false cord and the whole of the supraglottic region. So we booked the patient for theater, of course, after obtaining consent, and we did a pan endoscopy and a biopsy, and proceeded to do a tracheostomy for her. And we noted that she had this fungating tumor, which was involving mainly in the supraglottis region. Both false cords were involved. The ventricles were also involved. And there was edema of the epiglottic folds and arytenoid mucosa with the erosion of the epiglottis and cartilage exposure on the laryngeal surface of the epiglottis. However, the true vocal cords and the subglottis were spared. And on the histopathology result, I should say it was not a sort of like a simple a confirmatory diagnosis, as initially the pathologist, they did give me a call and said it looks like an acute inflammatory process. And then later on, this entertained the diagnosis of a large B-cell lymphoma. And it took almost a week and they had to involve their lymphoma sort of specialist to also have a look at the histopathology result after the immunohistochemical stains. However, because of I can't log into our lab system, but I was happy to share the immunohistochemistries. So the histopathological confirmation confirmed a diagnosis of an EPV-associated large B-cell lymphoma of the non-germinal center subtype with ulceration and CMV infection. However, TB and fungal stains were negative. So in terms of my discussion, laryngeal lymphoma is quite a rare entity, and I thought maybe I could discuss an approach to difficult airway due to tumors of the larynx briefly, and briefly discuss the features which are suggestive of a lymphoma of the larynx. And I will share a few slides on features of a non-squamous cell carcinoma diseases of the larynx, which we don't usually encounter. So I thought I could share with you this article, which was published in June 2020, which basically sort of like discusses the multidisciplinary approach to a difficult airway. It was published by Professor Ross Hofmeyr. He's also on the platform, Richard and Professor Richard and Professor Fagan. So basically, if you look at it, it looks at the pre-operative sort of airway assessment, and includes the intraoperative airway assessment in terms of how you sort of plan a difficult airway with the anesthetic team, and also discusses options in an emergency airway case, or a very difficult patient in which you can't use a flexible fiber optic nasal endoscopy, and if the patient is also not cooperative enough to sort of tolerate an awake tracheostomy. So so in terms of approach to a difficult airway, this requires a clear discussion between the anesthetic team and the surgeons, as in this case, after recording this the findings of the flexible nasal endoscopy that we did on the bedside, I shared this video with the anesthetic team so that they get a sense of how we can approach the airway. So the fundamental decision in a case of a difficult airway is either you are going to manage the airway awake, of which we have got an option of one, a fiber optic nasal intubation, or an awake tracheostomy. And the other option is, the other question is, you want to ask yourself is it safe to actually induce this patient and intubate, taking into consideration the available expertise, the resources at your disposal, and the equipment that is available. And you also want to look at the patient factors and as well as the disease factors, as you will find that at times these tumors which are involved in the supraglottis sort of obscure your visualization of the glottis or the airway, and which may make it difficult for you to employ an awake fiber optic intubation. And in that case, you may opt for an awake tracheostomy. And so you should always take into consideration all these different sort of factors. So as you prepare for a difficult intubation, it is of paramount importance that the entire team should be present in theater during airway management and induction. So you make sure all the routine emergency airway equipment are present, and rescue devices like your operating laryngoscopes, your rigid bronchoscopes, cricothyroidotomy set, and the tracheostomy set, and jet ventilation sets should be on hand. So I can not overemphasize the importance of a clearly discussed airway strategy, which includes a comprehensive a checklist and algorithms to use in case of emergency. So it is of importance that as the ENT surgeon, you sort of like pre-plan for your tracheostomy, and you do your markings before the attempt of awake fiber optic intubation is made. So you want to infiltrate half midway between your sternal notch and your cricoid cartilage, and make sure you are scrubbed and the scrub nest is ready with all the necessary instruments for emergency airway on hand. And you make sure you have adequate lighting and adequate suction. And then I think Professor Ross Hofmeyr is also on the platform. I would invite him to comment on the approach to the difficult airway situation.
Hi, Charles. Yeah, thank you. I think you've actually summarized it really quite nicely. And thanks for referring to that publication. For the people online, if you'd like a copy, I have dropped the PDF into the chat. And if people who joined later can't access it, I'll drop it again at the end of the conversation. I think you've touched on the most important points, which is number one, the preoperative assessment of these patients, and it's very, very useful to have your anesthetist involved in that. If you are going to do an endoscopy in rooms or in the ward, before the procedure, it's very useful if that's recorded and the anesthetist can see a copy. Nowadays, it's often very easy to send a video recording. Or alternatively, if you are doing a preoperative assessment, in the days prior to surgery, to invite the anesthetist to join you for that scope. Otherwise, we will often do what we call PEAE, which is preoperative endoscopic airway assessment, which we can do in the induction room just prior to the patient coming to theatre, and get a good idea with the patient who is awake and topicalized how tricky the airway is going to be. For tumors around the glottis, an emerging technique, if we don't have very recent CT scans or MRIs, or in an environment where that's not available, is to use airway ultrasound. And that can often give one an impression of what's happening to the airway below the glottis, or where it's not easily visible with a scope. And the fundamental decision, which we talk about in some detail in the paper, is whether we need to keep the patient awake for the intubation to make sure we've got control of the airway, or whether the airway difficulty is amenable to putting the patient to sleep and perhaps using video laryngoscopy or even direct laryngoscopy for our intubation. Obviously, as Charles was alluding to, tumors around the glottis sometimes obscure the subglottic area, and it's difficult then to know whether one can simply pass a tube with direct or video laryngoscopy. And that's when it's particularly useful to have well topicalized the patient's airway and be able to pop the scope through and actually have a look. Preloading a small diameter scope with a microlaryngostomy tube is often a very effective strategy, because then if one sees that it's going to be a tricky airway, one can continue with topicalization, a sort of spray-as-you-go technique, and simply proceed to intubation. So yeah, I don't want to harp on about it too much, but I'm very happy to answer questions or respond further if you like, Charles.
Thank you very much, Professor Ross. Maybe we can take the questions at the end. I will continue the presentation. So my next discussion point is the hematolymphoid tumors of the larynx. So either a primary or secondary, the hematolymphoid tumors of the larynx are quite uncommon, and the extramedullary plasmacytomas being more common than lymphomas. And if you look at lymphomas, the most common subtypes are the B-cell derived types of lymphoma. And Epstein-Barr virus is also found in up to 50% of AIDS-related non-Hodgkin's lymphoma. So if you look at lymphomas of the larynx, fewer than 100 cases have been reported in literature, that is according to Cummins. And they are more commonly secondary involvement from regional disease. However, you can get primary lymphomas, of which diffuse large B-cell lymphoma is the most common, and extra nodal marginal B-cell lymphomas of the mild type being the second most common. I should say there is sort of a limited role of surgery in isolated lymphomas of the larynx, because usually if the treatment is directed towards the type of lymphoma rather than the site. So there is, I thought I would share with you this WHO classification of AIDS-related lymphomas. So number one, you can get lymphomas that also occur in immunocompetent patients, like Becky's lymphoma, which has been shown to occur even in patients with reasonable high CD4 counts, and diffuse large B-cell lymphomas and Hodgkin's lymphomas also occurring in immunocompetent patients. And then we have got lymphomas that occur specifically in HIV positive patients, that is a primary effusion lymphoma, a large B-cell lymphoma arising from human herpes virus 8 associated multicentric carcinomas disease, and plasmablastic lymphoma. And then you also have got lymphomas that occur in other immunodeficiency states, like patients who are on steroids and patients who are transplant recipients. I thought I would share with you this paper which was published in 2013, which was published by Dr. Stephenson, Professor Shazia Pia from the University of Cape Town, Dr. Coven and Professor Faken. So they described 2 cases of a plasmablastic lymphoma of the larynx. The first case, it was a 49-year-old male patient who was HIV positive on ART, who was concurrently on TB treatment, who presented with a bulky fungating supraglottic tumor, no associated cervical lymphadenopathy, but had anterior chest wall nodules. So it is a sort of a common entity for plasmablastic lymphoma as well to involve the skin, but it is commonly involves the oral cavity, that is the hard palate and the gingiva, but you may get it in other sites like the parotid, the pharynx, and other sites in the head and neck region. And the second case was a 41-year-old lady who was also HIV positive on ART, the history of previous TB treatment, who also had a tumor involving the laryngeal surface of the epiglottis. And however, this patient had a synchronous nasopharyngeal tumor, which turned out to be a plasmablastic lymphoma as well. And the second patient required a tracheostomy, an awake tracheostomy due to airway compromise. I think from these 2 cases and the limited sort of data in literature, we see that lymphomas tend to present more in the supraglottic region. And it is also of paramount importance that you do a comprehensive airway assessment. And as you can see, that they may actually be in airway, present with airway compromise requiring a trachea. So in terms of clinical features, commonly these patients present with dysphonia or change in voice, or you may want to call it a muffled voice. It may present with a foreign body sensation in the throat, dysphagia with a sore throat, and if in advanced disease, they may present with airway compromise. As I have alluded previously, the supraglottis is the most common site, with the R epiglottic folds being the most common subsite. But we have seen that it can involve the epiglottis and the arytenoids and the false cords and the ventricles, as we have seen in this case I just presented. So I would like Dr. Mohammed is also on the platform. I would like to share, maybe she can share with us our local experience in terms of the incidence and how we stage and manage these lymphomas.
Hi, morning everyone. I'm sorry, I'm going to have to dash off because I'm already late for my 9 o'clock planning session. But lymphomas can occur anywhere. We haven't seen many in the site, but we have seen more plasmablastic in the site, as you've described that article. And Epstein-Barr virus is common in lymphomas in HIV positive patients. This woman is quite immunocompromised. We'll treat her with chemotherapy. We'll treat her with R-CHOP, rituximab-based chemotherapy, 6 cycles, and she has, I think, really a good chance of cure. Her CT scan, staging CT scan, demonstrated small lymph nodes, sub-centimeter lymph nodes above and below the diaphragm, with the largest ones being inguinal that were a little bit larger than a centimeter. And she also has lung involvement. I think this is more likely HIV related, and the lung involvement is more likely TB related. And we'll discuss with the ID team, because we're actually co-managing her with the ID team. They've initiated ARVs. They've also decided to treat the CMV. So we'll work together with them, but I suspect that that she's actually a stage 1E lymphoma. And if that's the case, her only poor prognostic indicates the fact that her LDH is up. And she should really do very well with maybe 80% long-term survival with just chemotherapy, 6 cycles. I think when you said the histology took long, I looked at the histology report again. I think it might be because there was so much inflammation there. Because they did eventually find this diffuse lymphoproliferative lesion. So yeah, I think it's just all that inflammation that kind of confused the issue a little bit. And actually, I think the pathologist that reported might be quite junior, so I had to go and speak to Dr. Chetty, so I think that's the only reason it took a bit long. I mean, I think if it was someone who was more familiar with this, it probably would have been a bit, looking at the fact that she's HIV and she's defaulted out, would probably have. But I mean, if you look at the immuno, these are all just the typical immuno that we would do for lymphoma. So yeah, I don't know why it took a bit long for your result.
Well, on that note, I had one question. What's your take in terms of steroid use prior to obtaining a biopsy for lymphoma? Does it have any impact in terms of delay in the diagnosis or staging process or causing a diagnostic sort of dilemma?
You obviously know the answer to this question. That's why you asked it. Lymphomas are very sensitive to steroids. So we would, if we suspect a lymphoma, we would not want any steroid use because it means that when they finally look at the tumor, it might just look necrotic. We'd also prefer not to have any steroids until after we've done the bone marrow biopsy. But if that's not possible, then it doesn't really matter. She's had a bone marrow biopsy. We're waiting for that result. But yes, if you suspect a lymphoma, try not to treat with steroids unless you think the patient's going to die if you don't give steroids. And then in that case, they would respond quite quickly to steroids. But if it's a really high-grade lymphoma, like a Burkitt's lymphoma, you might push them into tumor lysis syndrome by just giving a touch of steroids. So that's another risk with lymphomas and steroids.
Okay, thank you. And is there a role of radiotherapy?
Yes, there is. You can give involved site radiotherapy after you've completed chemotherapy. But it kind of depends on the site. And for a patient like this with a laryngeal tumor, I would rather stay away because I think the morbidity associated with radiotherapy would be a little bit worse. And there's not enough evidence that it will add that much to this patient after the chemo. And with rituximab, the rituximab is the one thing that has been the game changer in the treatment of B-cell lymphomas generally and in the HIV positive group.
Okay, then one last question, and then how would you manage this patient different if they get recurrent disease or sort of residual?
Yeah, any recurrent lymphoma is treated with high-dose chemotherapy because the salvage would be stem cell transplant. Unless there's a contraindication to stem cell transplant. And HIV actually isn't, but we have found that it's a bit more difficult to salvage these HIV positive patients. If she does recur and she's not a candidate, and we first discussed with hematology, a candidate for stem cell transplant, we would actually then palliate with radiotherapy, which is really good palliation as well for lymphomas.
All right, thank you.
Anything
I'm not
else?
sure if there are any other questions before I can't see any raised hands.
Rahuf, I see a raised hand there by one of our honorary past registrars and fellows. Rahuf, would you like to ask a question or make a comment? Okay, nothing there. Charles, you can continue.
Okay. Thank you very much, Dr. Mohammed.
I also want to thank you, Charles. Your presentation was really good and extremely concise, and you really mentioned all the important things. So good job.
Okay, thank you so much.
Thanks.
Thanks everyone for joining. Charles, are you done with the presentation?
Not yet. I need 5 more minutes just to share the other 9 SCC sort of conditions, just the images. But I think Dr. Mohammed can be excused. If there are any more questions, I will bring them through after the presentation. So I thought I could share with you some of the laryngeal sort of features of other common disease entities. So in the context of HIV, it is actually important to include TB as part of your differentials. And if you look at laryngeal features of TB, according to the 8th edition of Scott Brown, it says that it invariably sort of occurs with the pulmonary component of tuberculosis, and it usually involves the posterior third of the glottis with this diffuse redness and edema, as you can see on the right vocal cord there. However, Cummings sort of described a different picture. Is stated that it doesn't necessarily have to follow an infection, a pulmonary TB component. It may sort of be attributed to a hematogenous or lymphatic spread. And the saying that it usually involves the posterior third of the glottis is they say it is sort of like not so much true nowadays, because it has been shown that it commonly involves sort of the vocal ventricular and the RA epiglottic folds, as well as the posterior glottis. And in the context of HIV, it is important again to have Kaposi sarcoma at the back of your mind. But in these patients, usually they've got concomitant cutaneous lesions. So it is important to examine your patient fully. I can recall one case of an upper aerodigestive Kaposi sarcoma who had lesions on his leg as well. However, laryngeal involvement is rare, but you may see these red purple mucosal lesions with associated generalized edema. Sarcoidosis may also present in the larynx. However, it is rare, and it also commonly affects the supraglottis, that is the epiglottis, your A folds, and your arytenoids. And the pathognomonic features are thick edematous pale or pink mucosa, as you can see in these sort of pictures. It is a chronic disease, so you can see there is a bit of mucosal atrophy here, and the hyoid bone is quite prominent, and there's also a prominent hyoepiglottic ligament. And you may get vocal cord palsy if you get perineural invasion or as part of a central nervous system or cranial nerve polyneuritis. You also can get granulomatosis with polyangiitis, or formerly known as Wegener's granulomatosis. This disease entity commonly affects the subglottis and the trachea, and only about 25% of the patients have laryngeal involvement. I won't go into much detail about this. And also you can get pemphigus, which also pemphigus lesions, which also commonly occurs with nasal symptoms, and it commonly affects the supraglottis, the laryngeal surface of the epiglottis, the AE folds, and the arytenoid mucosa. And it's also characterized by mucocutaneous blebs. And you find that in the mucosal surfaces, the epidermis sloughs off, especially in the aerodigestive tract, and then you are left with this tan fibrinous base with the halo of erythema. Rheumatoid arthritis may present in the larynx as well. You get laryngeal involvement in 20 to 30% of cases. you have either of the two phases. In the acute phase, you get erythematous and tender larynx with sort of red swollen arytenoids, and chronically you get cricoarytenoid joint ankylosis, which may cause problems with voicing. You may as well get bilateral vocal cord palsy from that, and it may lately present with also a submucosal nodules, which are amenable to resection via microlaryngoscopy. You also get relapsing polychondritis, which may affect multiple sort of cartilaginous areas like your ears, your costal cartilages, your trachea, your larynx, and your bronchi. So if it's affecting the laryngotracheobronchial tree, it carries a very high mortality rate of about 10 to 50%. So as you can see in this picture, you get this sort of thickened mucosa. This is during inspiration, which then collapses during expiration. So they may present in an asthma-like picture with wheezes, and it may be easily mistaken for asthma. And lastly, in the context of HIV, you also want to have infections at the back of your mind, in addition to TB. So you can get syphilis, candidiasis, histoplasmosis, blastomycosis, actinomycosis, which usually present with chronic suppurative lesions, leprosy, cryptococcosis, and also coccidomycosis. So it is important to include these or to have these differentials at the back of your mind if we are faced with an immunocompromised patient. And in summary, laryngeal lymphomas are rare. However, you should have a high index of suspicion in a young immunocompromised patient who is presenting with the tumors of the larynx, especially in the supraglottic region. And I cannot overemphasize the importance of a discussed airway strategy with the anesthetic team. And as I have alluded previously, that there is a limited role of surgery in laryngeal lymphoma, since the treatment depends on the type rather than the site of the lymphoma. Thank you very much. That's the end of my talk.
Thank you, Charles. That was an excellent and very comprehensive presentation on a very broad topic, including airway and laryngeal tumors. Is there anyone who would like to ask a question or comment? I would just like to ask Professor Pierre, who's heading up the pediatric ENT unit at Red Cross, to comment on especially papillomas and laryngeal tumors, which could include lymphomas in kids. Thanks.
Thanks, Gerrit. No, I'm not sure that there's much time to discuss the PED stuff. I think, Charles, you did really well. And probably the only thing to make note of is you get papillomas in children and also in adults. So the presentation could have been a papilloma in this case as well. So not to forget that. And in children, there's a whole lot of other things to consider with congenital things. The one thing of note is that the supraglottis actually does have lymphoid tissue. So it is part of the differential for any lymph type pathology because of lymphoid 6. But thanks very much. I think the PED stuff is at another time. But thank you. Thanks for referencing 2012.
And thanks, Charles. Charles, do you have any closing comments?
Not really. Thank you so much for all the participants and all the comments from Professor Ross of Meyer and Dr. Muhammad. We really appreciate their presence, and also look forward to engaging them in our future presentations as well.
Thanks to everyone who joined our meeting. I will end us off. A reminder of our meeting next Wednesday on a topical discussion, and enjoy the weekend. Cheers.